Okay, so I'll start again. So good evening, everybody. We have a subject seminar on acute pancreatitis today. It is a very common emergency that we all face on a day-to-day basis. And it is also a disease which even today has a mortality between 20 to 30% depending on the severity. So the importance of it is to understand as soon as the patient comes, to triage them in a way that you identify patients who are at risk of going into complications and then treating them appropriately so that you prevent and abort the severity of the attack and ensure that the patient recovers well. So that is where our energies have to be focused. We need to know where we have to intervene as surgeons. We need to know when not to do anything and just manage them conservatively. So Nikitha is going to talk to us about this to see what is the current state of affairs. Okay, over to you, Nikitha.
Yes, sir. Good evening, sir. Good evening, everyone. So today's presentation is about acute pancreatitis. And so the plan of presentation is first we'll talk about introduction to pancreas as well as pancreatitis and the proper definition of pancreatitis, and the classification, how the patient presents with the symptoms, and what are all the investigations we are going to do to assess, and the plan of management. So acute pancreatitis is a common disease and it is a leading cause of hospitalization among gastrointestinal disorders. It's major disease that cannot be self-limiting as it has serious early as well as long-term impact. Pancreas is a glandular organ which is both exocrine as well as endocrine in nature. Majority of 83% of the pancreas mass is exocrine in nature. Pancreas consists of head, neck, body, and tail in anatomical division. It's around 15 to 20 centimeters in size, weighing from 75 to 200 grams. From exocrine nature, it secretes amylase, peptidases, and lipase. Whereas hormones, it secretes glucagon, insulin, somatostatin, ghrelin, and pancreas peptidase. We are more interested today on exocrine secretions because that is where the whole pancreatitis is involved. So diagrammatic representation of pancreas goes like this. This is the head of the pancreas, whereas this is the neck, this is the body of pancreas, and this is the tail. On a microscopic view, these are the pancreatic acini. This is the exocrine part of the pancreas. This is the endocrine part, which consists of alpha, beta, delta cells, which are involved in hormone production. There's one pancreatic duct which connects all the interlobular ducts and joins the common bile duct into the to open into the duodenum via sphincter of Oddi. Sometimes there could also be a necessary pancreatic duct.
No. Wait. Go back. It doesn't open into sphincter of Oddi. It opens into the ampulla of water.
Yes.
Okay, sphincter of Oddi guards the ampulla. It doesn't sphincter. How can it open into a sphincter, ma? Sphincter is only a smooth muscle complex which controls the function or movement in and out of mainly out of the duct. So it opens into the ampulla of water. Okay. Yes. And it is not that there is only accessory pancreatic duct is there in most people. It usually, the main pancreatic duct is called the duct of Versung, and the accessory pancreatic duct is called the duct of Santorini. The ventral bud and the dorsal bud that pancreas develops from, the majority of the gland comes from what? Anybody? Dorsal or the ventral bud?
Ventral bud, sir.
Ventral bud.
Sure? That's the homework for you guys. Put it up in the
Dorsal bud,
class.
sir.
Okay, anyway, I didn't want to say the answer. So you put it up, go through, check it and put it up. Okay, so that will make sure that you remember. Now, so the duct that represents the dominant portion of the pancreas is called the duct of Versung, and then the other portion that develops from the other bud. I don't want to give you the answer. That will be the duct of Santorini. So sometimes the two of them meet together, but otherwise they can be separate also. That is called
Pancreatic divisum.
pancreas divisum. Okay, so majority of the times the two ducts meet. So it is not as if the accessory duct is only present in some group of people. It is present in most people. Okay, continue.
So the most common diseases of pancreas involved are pseudocyst, cancer, acute pancreatitis, and chronic pancreatitis. So today we'll be dealing about acute pancreatitis. By the definition, according to revised Atlanta classification, it has to acute pancreatitis it requires 2 out of 3 criteria. First one being abdominal pain consistent with pancreatitis, which is a severe onset of acute pain, abdomen, and a serum amylase or lipase 3 or more times the upper limit of the normal, whereas the normal limits being for serum amylase it's around 25 to 125 with upper limit of 125 units per liter, and serum lipase is 10 to 140 with upper limit of 140 unit per liter. So the third point is findings consistent with pancreatitis on cross-sectional abdominal imaging like ultrasound or CCT abdomen. So, so minimum 2 out of 3 is required to diagnose. Care is required as the first 2 criteria alone may fail to identify a quarter of patients with acute pancreatitis, while diagnosing 1 in 10 patients with acute pancreatitis incorrectly. So the most common cause of acute pancreatitis.
Sir, I have a doubt, sir.
No, I would.
Sir,
Yeah,
yes.
yeah.
Sir, that imaging finding should be there, sir, because in early stages,
What?
like in order to diagnose the acute pancreatitis, the imaging finding should be there. I'm asking, sir.
No, not necessary.
Yes,
See,
sir.
the thing is, you know, as we said, we'll come to that later. But
Yes.
the investigations at the beginning, we only do an ultrasound scan of the abdomen, and ultrasound scan will tell us whether there is edema, bulky head of the pancreas with the hypoechoic pancreas with fluid collections around the pancreas. And if there is obviously gallstone disease which is causing the pancreatitis, it will tell us if there is gallstones, pancreatic duct, or common bile duct dilatation. So these are the findings that we pick up on ultrasound, and that is all we need. But the 2 criteria, you see, the doubts come in when there is equivocal findings in terms of the history and clinical examination. But history is very classical, severe, what Lord Moynihan described as illimitable agony. So this is one of the most painful conditions you can ever face. So which is why pain relief is extremely important. And the pain is so severe, boring kind of pain in the upper abdomen, epigastrium, and umbilical region with radiating to the back, severe back pain as well. So the severe back pain becomes, later becomes more of a characteristic of chronic pancreatitis, where abdominal pain as such may not be there. It's only mainly chronic backache, which causes seen in chronic pancreatitis. So pain and then serum amylase and lipase, these are the 2 most important criteria in the initial phase. And of course, ultrasound scan of the abdomen. So 2 of the 3 criteria should be fulfilled according to the revised Atlanta classifications. Okay.
Yes, sir. So the most common causes of acute pancreatitis include gallstones, alcohol use, and hypertriglyceridemia. The rate of occurrence of each etiology of acute pancreatitis varies across geographical regions and socioeconomic strata. The mortality of acute pancreatitis ranges from 3% in patients with mild edematous pancreatitis to as high as 20% in patients with pancreatic necrosis. So, to summarize the whole etiology, this table shows it can be classified as mechanical, toxic, and metabolite, and other causes of acute pancreatitis. The mechanical being all the causes which are which involve the pancreatic duct either obstruction or like congenital malformations, which include gallstones, the first and foremost common cause of acute pancreatitis. And the duct obstruction, it could be either due to malignancy or dysfunction of sphincter of Oddi, and in case of abdominal traumas, and any other causes of ampullary obstruction. And as mentioned, in case of annular pancreas congenital malformation. And in case of toxic and metabolite causes, alcohol is the primary cause, and hypertriglycemidas and drugs like azathioprine, rifampicin, and erythromycin. Few other drugs which are divided into class 1A, 1B, 2, 3, and 4, depending upon their association with the acute pancreatitis, ranging from very mild association, like in case of re-exposure, do they occur or not, to complete association with the drug. And scorpion venom is also a cause, and in case of organophosphorus poisoning and hypercalcemia. Other causes being iatrogenic, the most common one is ERCP, post-ERCP, pancreatic duct injury can cause acute pancreatitis, and in case of infection, and hereditary cases where there is specific gene mutations like PRSS1 gene, and in that case also we find acute pancreatitis and congenital cystic fibrosis.
Go back, ma.
Yes, sir.
See the drugs. Are you sure rifampicin is there in that in the thing?
Not rifampicin, sir. Rifampin is there in class 2, sir.
Okay. And iatrogenic, you also have to mention post-operative pancreatitis. There are upper GI surgeries, gastric surgery, and occasionally post cholecystectomy. So these things are also should be mentioned.
Yes, sir.
Post-operative. Okay.
Yes. A stone obstructing the sphincter of Oddi was the first ever reported confirmed etiology of acute necrotizing pancreatitis. And with respect,
just a minute, ma. Can you hear me properly?
No, sir. Actually, there is a lot of disturbance, sir.
Okay. That is why I have to log out and then log in again. Just a minute.
Sir, shall I continue, sir?
Yeah, can you hear me?
Yes, sir. Clear, sir.
Okay.
Yes, sir. And
You were saying about your what is that? Some you said something about sphincter body. Okay, carry on. I'll when I get it, I'll tell you.
yes, sir. Increased risk of acute pancreatitis, notably on the background of heavy alcohol consumption, is the primary cause in few areas. Like, so how much alcohol is too much alcohol? In that case, in USA, heavy drinking is defined as 210 grams of ethanol per week in men and 112 grams in women. So this is one of the cause.
Why do you think there is a difference between men and women, ma?
It depends upon the content of water in the body, sir. Actually, the absorption rates and everything differ. Depend
Not just
on body
water,
water to
not
weight
just
ratio,
water.
sir.
Fat also.
Fat, sir.
Okay. How did they actually identify gallbladder stones to be the cause of pancreatitis? Does anyone know? I've told it somebody, at least some people, many times. I don't know if anyone remembers. See, there was a very elegant paper by Asopa et al., who actually what he did was he strained the stools of these patients who had gallbladder stones and pancreatitis and found small stones that pass through. So that is why he was able to demonstrate the cause-effect relation between gallstones. See, it is usually tiny gallstones that pass through and then temporarily gets blocking the gets stuck at the ampulla and causing back pressure onto the pancreas and causing pancreatitis. So he was able to demonstrate by this operation, this study, that gallstone and pancreatitis has a cause-effect relation. Okay, continue.
Yes, sir. So there is approximate of 4% increase in incidence of acute pancreatitis for every 100 milligrams per deciliter rise in serum triglyceride levels above 1000 milligrams per deciliter. And ERCP is associated with significant risk of acute pancreatitis patients, greater risk in younger women with small and normal bile ducts and sphincter of Oddi dysfunction. So the basic pathophysiology behind acute pancreatitis on a molecular level is that all the causes of etiology, when they trigger, they induce an injury to pancreatic acinar and ductal cells, either by obstruction or by the toxicity they produce. So this disrupts the intracellular calcium signaling system, which induces mitochondrial permeability for the in general permeability of mitochondrial membrane, and this causes loss of potential drive for the production of ATP. Similarly, second messenger release mechanisms are also induced in alcohol associated acute pancreatitis cases. So by fatty acid release from the fatty acid ethyl esters or lipolysis of triglycerides in hypertriglyceride media to inhibit mitochondria and aerobic ATP production. So diminished ATP production results in defective autophagy and co-localization of zymogen granules, and endolysosomes and zymogen activation occurs, which results in cytoskeleton disruption and diminished zymogen secretion. This also causes inflammasome activation, finally resulting in cytokine release and cellular necrosis. So multiple cytokine mediate a powerful pro-inflammatory immune response, notably tumor necrosis factor alpha and interleukins 1 alpha, 1 beta, 6 and 18. These exacerbate the initial pancreatic injury. So as the inflammatory reaction goes on goes into cascade, resulting in spread via lymphatic and systemic circulations into liver, lung, heart, kidneys and gastrointestinal tract, resulting in multi-organ failure. This causes the systemic inflammatory response and as an early clinical feature and persists in moderately and severe to acute pancreatitis. So as the image demonstrate, in uncomplicated acute pancreatitis with no necrosis, there is mild inflammatory reaction which doesn't cause any systemic complications. But in case of severe acute pancreatitis with necrosis, it causes a cascade of inflammatory reactions resulting in severe inflammatory response as well as multi-organ dysfunction. So most extremely, a cytokine storm syndrome results through positive feedback loops between cytokine release and program-mediated immune cell death, resulting in multi-organ dysfunction. So as the process of acute pancreatitis is going on, we need to assess the patient to identify the level of disease he is in for the further
Severity.
management. So there are
Level of severity.
yes, sir. The prediction of severity is made as early as possible after admission to determine which patients are likely or not to develop local or systemic complications who may benefit from early or more intensive management. So severity assessment and prognostication are essential to determine the level of care. Multiple clinical prediction scales are developed and validated and are cumbersome, which calculate immediate as well as within 48-hour data. The scoring systems which are available right now for the acute pancreatitis are Ransom scoring system, which is a 11 variable scoring system which includes assessment of the patient at the time of admission as well as at the end of 48 hours. The next one is modified Glasgow scale. Bedside index is the most common one which we use because it is feasible and probably more accurate. POT is pancreatitis outcome pointing score, and SOFA is sequential organ failure assessment score, and modified organ dysfunction scores. So, bedside index for severity in acute pancreatitis has 5 components, which is of blood urea nitrogen if it is greater than 25 milligrams per deciliter, or impaired mental status if the Glasgow Coma GCS score is less than 15, and severe immune respiratory evidence of severe inflammatory response syndrome. It has like 4 components. If the temperature is below 36 or greater than 38 degrees Celsius centigrade, and the heart rate greater than 120 per minute, respiratory rate greater than 20 per minute, and total count being less than 4,000 or greater than 16,000. That includes 1 point in SIDS, and age of the patient is greater than 60, and pleural effusion gets 1 point. So 1 to 2 point indicates low mortality of less than 2%, whereas 3 to 5 points indicate high mortality, more than significantly more than 15%. The modified CT severity index is also an important score. So this includes from the CT, the image based points, whereas normal ranging from normal pancreas to peripancreatic fluid collection and fat necrosis. And in necrosis, the amount of necrosis is also quantified. Based on this, the scoring is given 0 to 2 is mild, 4 to 6 is moderate, and 8 to 10 is severe. So this scoring will help us to know the severity by, in case of mild acute pancreatitis, absence of local or systemic complications or organ failure, these patients can be managed conservatively without any ICU admission or any extra assessment requirement. In case of moderately severe acute pancreatitis, are local complications with or without involvement of organ failure, these patients need observation. And in case of severe acute pancreatitis, there is a persistent organ failure for more than 48 hours with involvement of one or more than one organs. These are the patients who are needing ICU care. The
Okay,
Atlanta
just a
classification
minute.
based on the pancreas involvement, it is
Nikitha?
yes, sir.
Just stop for this matter. Indraja. Hello?
Yes, sir. Yes, sir.
Pavan joined the class.
Yes, sir. I think.
Pavan.
Yes, sir.
Between the two of you, you need to answer. See, Nikitha has only put up the BISAP grading. She's not spoken much about the IMRI or the Glasgow, modified Glasgow scoring or the Ranson's criteria. They are the ones which are most famous. Ranson's criteria was enunciated in 1974 and it has been there forever. And Glasgow criteria is similar, and that was, I think, in 1980 or something. So why is she only saying about BISAP grading and not about Ranson and class and IMRI classification?
Sir, ransom we
Ah,
have to measure at the admission and after the 48 hours, sir,
okay,
to assess the severity.
okay,
And Glasgow also we have to measure after 48 hours, sir.
correct. So what is the
Uh,
problem?
After 48 hours only we can measure the severity, but Bishop says we can measure it on the day of the admission to assess the severity, sir.
What is the big deal? Anyway, patient is admitted. So why not wait for 48 hours? Pavan,
Sir,
huh?
sir, before 48 hours, in case of severe pancreatitis,
See the answer. Sania, can you take that question?
No, sir, I'm not sure.
See, basically, there are very good studies now which have compared the Ranson prognostic criteria, Glasgow and BISAP staging, and BISAP comes out very well. It is equivalent or even better in predicting the severity. As you said, the advantage is it predicts it on admission at one go. So you can stratify the patient as mild or severe. There is moderate. I don't know whether whether the latest Atlanta classification says mild, moderate, and severe. It's only on the CT. But I think in terms of the clinical staging, it is acute pancreatitis and acute severe pancreatitis, mild and severe, only two. So the BISAP grading gives you an answer fairly quickly. So, of course, some patients initially who are mild may turn out to be severe. Usually the vice versa doesn't happen. Somebody comes in severe will not turn mild after 48 hours. So it's usually patients, some of them may appear mild and then become severe. But majority of them, mild pancreatitis, as Nikitha said, can be managed conservatively on the ward, give them, rest the pancreas and give them IV fluids, ensure that they are well hydrated, give them analgesia, and then you don't need to start antibiotics in these people and they tend to get better. The severe ones, you need to nurse them in the intensive care. You watch them very carefully, give them all the treatment. We'll come to the treatment later, but you need to take all the precautions to abort a severe attack and organ dysfunction, and sometimes even prevent some complications and make sure that the morbidity and mortality are kept low. So this stratification helps to, in very practically, it helps to manage the patients. So that is why it is important. The Glasgow and the Ranson criteria, though they are good in predicting severity, they have the inherent problem in terms of delay of 48 hours, which the BISAP grading doesn't have. And also it is equivalent in terms of predicting severity. So that is why now BISAP grading There is other thing called PANC3 scoring also, which again I think is similar, but PANC3 only predicts very severe attacks only. It doesn't, is not good very in predicting the mild pancreatitis. So that is why now the BISAP grading is, sort of, and if you want, you can also put this Apache 2 scoring, but again, that is also very cumbersome, lot of parameters. So BISAP grading has very few parameters, and it is quite easy to do quickly on the bedside, and hence it is gained popularity. So that is the answer. Did you follow? Hello?
Yes, sir. Yes, sir.
Okay. Nikitha, carry on, ma.
Yes.
BISAP scoring is done on admission or after 48 hours?
No, admission, on admission.
Ransom
All the
is
Ransom has two components. I mean, two different types of variables. One, a set of variables are done at the time of admission, whereas the other set are done after 48 hours, sir.
Okay.
So the Atlanta classification broadly classifies acute pancreatitis into two categories, depending upon the involvement of the pancreas. Interstitial edematous acute pancreatitis, which involves pancreatic parenchyma and surrounding peripancreatic tissue. There is only acute inflammation, whereas the second type is necrotizing acute pancreatitis. It causes necrosis of the pancreatic and peripancreatic tissue. So the local complications of acute pancreatitis are early, which is less than 4 weeks. In this case, there is peripancreatic fluid collection and also peripancreatic necrosis. And the late complications are pancreatic pseudocyst formation, and there is a clear defined wall of collection and necrosis. So when the patient presents to the emergency or OPD
Go
with
back,
complaints, sir?
Go back. So are these the only complications? Pancreatic fluid
These are the
collection,
local
pancreatic
complications, sir.
local complication. What about pancreatic ascites? It's not a complication.
pancreatic abscess,
Pancreatic abscess, pancreatic ascites, infected necrosis,
aneurysms,
this is splenic artery aneurysm.
Yes, sir.
They're all local, and also splenic artery mesenteric
thrombosis.
vein and mesenteric vein thrombosis, portal vein thrombosis. All these things can happen, ma.
Yes,
Lot
sir.
of them. They're all local complications only.
Okay, sir.
Gastric outlet obstruction. All these are local complications. Okay, carry on.
So patient presents with the complaints of epigastric or diffuse abdominal pain in most of the cases, and nausea and vomiting, and in few cases abdominal distension, fever and breathlessness, irritability and impaired consciousness with pyrexia, fever, low oxygen saturation, tachypnea, tachycardia and hypotension in few severe cases, and abdominal guarding or ileus and or oliguria. So the nature of the pain can vary depending upon the etiology of biliary obstruction. So in case of biliary etiology, it is often described as sharper pain that radiates to the back with more acute onset. But in case of metabolic and toxologic causes like alcohol, it has a sluggish start with dull and generalized pain in the epigastrium. Medical history should include careful inquiry directed at etiology, including gallstones, obesity, excess alcohol consumption, smoking, and hyperlipidemias. The drugs and that induce the disease, recognizing that more than one precipitant may cause the disease. Family history is also important, as we have talked. There could be some hereditary reasons, causes. Differential diagnosis based upon the pain. These are all the conditions that could mimic the pain caused by pancreatitis, but each of them have their specific classic presentation which differentiates them from the pancreatitis. Most common ones are perforated ulcer, biliary disease like cholelithiasis and choledocholithiasis, mesenteric vascular disease, dissecting aneurysm, ectopic pregnancy and ovarian cyst, renal colic and myocardial infarction. On clinical examination, the patient, we might,
Go back, ma, go back. It's not infraction, ma, it's infarction. Myocardial infarction. Okay.
Yes, sir. Yes, sir. I'm sorry, sir. On physical examination, we identify if the patient presents, he might have fever, tachycardia, and in severe cases, hypotension. On perabdominal examination, there is epigastric tenderness with possible guarding or rigidity, and decreased bowel sounds might also be there. In extreme cases where there is retroperitoneal bleeding, so there is a Great Turner sign which presents as ecchymosis in the flanks, or Cullen sign where there is a ecchymosis in periumbilical region secondary to peritoneal hemorrhage. So
Any specific reason why ecchymosis are present at those points? Can you hear me?
Yes, sir. Yes, sir.
I don't know. That's why I'm asking.
Anybody? Sanya?
Sir, is it because of the dependent position, sir?
Has any book given any explanation?
No, I think as far as I know, these are very, rare signs. No particular reason is ascribed to it. I think it's just a, I think it's just an observation, that's all.
Okay.
Other thing you forgot to mention, Nikitha, is jaundice.
Yes,
You
sir.
need to, one of the things you have to observe in a patient with pancreatitis is the patient jaundiced. It will give you a clue as to the etiology.
Yes,
And
sir.
another important find is this one etiologic thing which you keep forgetting is hypercalcemia. As far as the, I think hyperlipidemia, of course, but hyperlipidemia, any types that you know of which causes pancreatitis? Hyperlipoproteinemia and hyperlipidemia types. Anybody knows which causes pancreatitis? Pavan, Indraja, you're going for exams.
No, sir.
No, sir.
So that is the homework. You need to check. Okay.
Yes,
And
sir. Yes.
hypercalcemia also. You have to be very wary of hypercalcemia. It's much more common than we think it is. Okay. Carry
Yes,
on.
sir. So investigation prior to diagnosis, oxygen and intravenous fluid resuscitation and pain relief management is usually indicated. So even before we start for investigations, we need to assess whether patient requires these things depending upon his presentation and go ahead with them. Initial investigations for suspected acute pancreatitis include serum amylase, lipase, triglycerides, the lipid panel, full blood count, renal and liver function test, glucose, HbA1c, calcium, and ultrasound scanning to identify the etiology.
Why you have written TUS then?
Trans-abdominal ultrasound, sir. I wanted to mention.
Okay.
You forgot to mention LDH. LDH is one important thing that they usually do. LDH also has, as far as the in Ranson's criteria.
Yes, sir.
It
In
is,
both,
it is one of the prognostic indicators. Ranson and Glasgow criteria. Serum albumin, I think, is in Glasgow, but LDH is found in both.
So, initial investigations, we are going to send all of them,
again,
sir.
you forgot to mention blood urea nitrogen. Again, that is very important. Your BISAP grading depends on blood urea nitrogen, no?
In a renal function test, we include that, sir. So.
Okay. Sorry, I didn't see that. Okay, right.
Yes,
okay.
So these are initial investigations, sir. We are going to send specific investigations again after the assessment, after the initial assessment.
Okay.
Both amylase and lipase lack specificity, as either can be elevated by other acute conditions, including peptic ulceration, polycystitis, mesenteric ischemia, or macroamylasemia. If the
Now,
patient,
this one amylase can be elevated with ruptured ectopic pregnancy,
Yes, sir.
perforated peptic ulcer, brain, this one, head injuries, all of these things. But then if your values are more than 3 times, majority of these hyperamylacemias, the values will not be more than 3 times. So if it is more than 3 times, it is more likely to be due to pancreatitis, in addition to having severe upper abdominal pain.
yes, sir.
Okay. So again, I think I spoke about this yesterday in the class, but you need to check amylase and lipase once. They are not prognostic indicators, they are only diagnostic indicators. And like most of the enzymes, it will go up and come down on their own volition. So value that is coming down does not indicate that the patient is getting better. It happens naturally. So you just need to do lipase and amylase once. You only repeat lipase and amylase if the patient stays in the hospital for longer, and then subsequently, once he's getting better and again starts deteriorating, then you may have to do the lipase and amylase to indicate whether there has been any of these complications relating to pancreatic fluid collection, pseudocyst formation, and all those things. Pancreatic ascites and all that, ductal disruption. So it's only once that you need to do amylase and lipase. Okay, carry on.
So if the patient conditions include pyrexia with or without rigors or chills, jaundice and bile duct dilation on ultrasound indicates cholangitis. ERC without pancreatic duct cannulation, sphincterotomy and stone extraction are appropriate. If it is available immediately prior to ERCP, endoscopic ultrasound is advised to determine whether such treatment is necessary. Without cholangitis, a conservative strategy is preferable.
Where did you get this, mark? Go back.
Yes, sir.
Where did you get this endoscopic ultrasound?
Sir, actually, it's in the recent article I have seen, sir. So they're recommending.
No, when the cause is not known, when you have got high suspicion, then you cannot rule out by other investigation, endoscopic ultrasound is performed.
Yes, sir.
Endoscopic ultrasound is not the
It's
standard.
very expensive. Yes.
It's expensive, and not many people know how to do it.
Yes, sir.
So skilled endoscopist is also required, and it's expensive, and the value that it adds is very minimal. So I think if you are in doubt before doing an ERCP, you do an MRCP. MRCP will give you a roadmap based on which you can do whether you can consider whether ERCP is indicated or not. We'll come to the treatment later. Just concentrate on the investigations now.
Yes, sir. So summarizes all kinds of investigations involved with acute pancreatitis. The purpose of investigations is to determine the etiology and to assess the impact and to plan the management. So on admissions, we are going to do the basic panel of investigations which do give an idea about the etiology of the pancreatitis and also the level of severity. And further investigations after admission, we are going to do C-reactive protein, virology titers, and MRCP, CCT, depending upon the patient's condition as well as the etiology. So investigation, lipase and amylase levels. So this is the graph representing the peak of the lipase and the decrease. It peaks at 24 hours and level decreases in 8 to 14 days. It remains elevated longer than amylase. Whereas amylase, it peaks in 12 to 72 hours and its level is elevated up to 14 days. On X-ray erect abdomen, these are the two important signs we might see. The colon cutoff sign due to the bulky pancreas, which is covering the colon, and also sentinel loop sign. Ultrasound images show the bulky pancreas. This is the head of the pancreas, neck and tail of the pancreas. If there is any peripancreatic fluid collection, it's going to show in ultrasound. And if there are also any etiology related to gallbladder biliary stones, ultrasound is useful to find out the etiology also. And the CT images, these are the 4 images indicating uncomplicated acute edematous pancreatitis. As shown here, it's just bulky with some peripancreatic fluid collection. This is acute necrotizing pancreatitis. There is a difference in the echogenicity. And this is necrotic collection of pancreas. This is post endoscopic necrosectomy. Changes of acute necrotizing pancreatitis, diffuse hypoenhancing pancreas and small non-enhancing areas within. This shows necrotizing pancreatitis, which is extensive with pancreatic nodularity along the route of mesentery. So the treatment of acute pancreatitis.
Okay.
Yes, sir.
Say, Pawan, I've told it many times. If you get this wrong, I'll hit you. What is the timing of CT scan? Pawan? Pawan, are you there? Indraja? Hello?
Sir, hello, sir.
Where is Pawan gone?
I'm not sure, sir.
Huh?
He's in duty, sir.
I know, but where is he gone? He had logged in, no?
Yes, sir.
What is the emergency? Is it an emergency in the emergency, or he's just gone because he doesn't want to be in the class?
No, sir. I think some patient is there in
Came back.
emergency.
Huh?
Hello,
Huh?
sir. Sir, some signal issues. I'm here only, sir.
You're there.
Yes, sir.
Okay. When do you do the CT? Okay. Reconnect, man. Indraja, tell us, when do you do the CT?
Sir, after 72 hours, sir, if patient is like having persistent pain.
What? After?
72 hours, sir.
How many times do we have to tell you? I don't know where you get the 72 hours business.
5 days.
5.
Ah.
4.
Who said 5 days?
Me, sir.
5. That is the correct answer. See, Indraja, I've told you so. Even yesterday in the class, I told you. Yeah, I know. Even MN Vijay Kumar agreed. See,
Yes, sir.
basically, most people, physicians especially, don't have a clue. If they admit a patient of pancreatitis, they'll get CT scan immediately. It is waste of money, waste of time, and also excessive radiation. So, clinical symptoms and signs, amylase, lipase, and other investigations, and ultrasound is sufficient for you to stratify the disease and then manage them. You then, patients who are getting better, you don't need to do anything. Majority of them by 2-3 days, about 70 to 80% of them recover and go home. So you avoided CT scan in majority of the patients. In patients who persist in the hospital, who are not improving, who have persistent pain or fever or whatever symptoms, not recovering and showing signs of organ dysfunction, at the fifth day, you get a CT scan to quantify the extent of pancreatic necrosis. This will not be evident in the first 48, 72, 96 hours, which is why it's not because I have anything against CT scan, but it is because it has been proven by extensive amount of literature that if you do CT scan early, it is not going to give you any more information than an ultrasound would have given you. So the quantification of pancreatic necrosis, the extent of pancreatic necrosis and presence of other complications like Shrikant said of splenic vein thrombosis or pseudoaneurysm and all these things will all start appearing after the 5th day, which is why the classification, the CT scan has to be done at 5 days. However, when the patient is admitted to the emergency and then to the ward with severe abdominal pain and the diagnosis is equivocal, where you don't know whether it is, the values of amylase and lipase are not significantly high, and you are not sure as to what is the cause of his abdominal pain and the etiology of his symptoms, then you are well within your rights to get a CT scan. So that is the only indication to doing CT scan early. Otherwise, reserve it after 5th day because it gives you better information then. Okay. And then depending on the progression of the patient, whether there is sepsis, multi-organ dysfunction, ARDS, acute renal failure, inotropic support, all of these, pneumonia, all of these things, if there is progression, then you have to do a serial CT to see whether the necrosis has become infected necrosis. Okay. Got it, all of you?
Yes, sir.
Clear?
Yes, sir.
Okay.
Yes,
Don't
sir.
forget this. Okay. Continue. Nikitha.
Treatment, we start by fluid resuscitation. Right now, we go with 5 to 10 ml per kg per hour. By closely monitoring the patient's urine output as well as his vitals. Depending upon that, we need to either increase or decrease the fluid. Most commonly advised fluid is ringer lactate. And as we're going to employ the practice of keeping nothing by mouth for the patient, the malnutrition is also a severe complication in that case. We need to, we generally plan to start diet after 24 to 48 hours. So initial soft, low residue, low fat diet is recommended.
What is the thing? Basis for low residue diet? Why low fat diet?
Sir, to not to stimulate the pancreas, sir, for the release of pancreatic enzymes, to decrease the induction.
Low residue?
For the gastric motility, I guess, sir.
See, the thing is, gastroenterologists seem to believe that nasogastric feeding is equivalent to nasojejunal feeding. The ideal thing to do would be to go past the C loop of the duodenum and feed them. And that way you are taking away any amount of even if it is minimal, the pancreatic stimulation of pancreas and autodigestion to continue if you stimulate the pancreas. So if you go past the C loop, then you can avoid that. So if you have the facility available, place a nasojejunal tube. You don't have to wait for 48 hours and all that, beyond 24 hours, because why you have to do this is first 24 hours you are concentrating on pain management, fluid management, oxygen and all these things, making sure the patient gets hemodynamically stable. Then see, 5 days of lack of nutrition is not going to hurt, but you don't know whether this patient is going to, beyond 5 days, is the patient going to need nutritional support or not? It's very difficult to predict at the beginning. So hence, after the initial first 24 hours of resuscitation and getting the patient hemodynamically stable, there is no rush to feed them then. Though you could potentially feed them then also, there is no problem feeding them. Feeding, we have actually done, we were the first people, unfortunately, we were beaten by Leeds, where I was in Scarborough when we started doing enteral nutrition for patients with acute pancreatitis. And we, I think the Leeds people beat us by 1 day. They presented 38. We had actually got 80 patients. So we had better data. Unfortunately, we thought we'll get up to 100 and then present. And by that time, Alistair Windsor and group from Leeds presented their 38 patient data of feeding the patients early. So that took away this, fasting the pancreas, that is not necessary. You can start feeding them, but you can't give them orally because they may vomit. And also, as you said, there is potential for gastric dilatation and gastric ileus. So which is why you don't feed them orally. And the other thing is, there are some people with severe pancreatitis where there is functional gastric outlet obstruction. So feeding them may not be very good in that situation. So hence, you pass a nasogastric or a nasojejunal tube and feed them after for 24 hours. Clear to
Yes, sir.
everybody? Okay, continue.
So, initiation of antibiotics is only limited to the presence of infected necrosis or any other source of infection in the body. And regarding the pain management, we do follow WHO and analgesic ladder, which has NSAIDs in step 1, low potent opioids and NSAIDs with adjuvant drugs in step 2, whereas high powerful opioid and NSAID plus adjuvant drugs in step 3, and interventional treatment plus high potent opioid plus NSAID plus adjuvant drug in step 4. So,
What are those adjuvant drugs?
Sir, in this case, the newer drugs include.
You right now, what are the drugs?
Yes, sir. Some protease inhibitors and immune modulatory drugs, and also anti-secretory drugs. So depending upon the patient's present etiology, they differ, sir. So if the patient has a cystic fibrosis, then drugs which could help with that.
Your cystic fibrosis is a rare cause. Common all mention about this thing, biliary pancreatitis and alcohol pancreatitis. What adjuvant drugs you give? Perhaps it is severe.
Nikitha, I think you have misunderstood what adjuvant drugs. It is only for pain management. Now, what are you talking about giving serine protease inhibitor and all that? It is about giving this, the pentazocine and other things. And, this, what is some of the, anesthetic drugs that are used for pain management. Etomidate and this one, what is the one which they use for induction of anesthesia? Propofol. All of these things, they are actually, what you have to say is that when patient comes and they are in severe pain, you can't say, I will go through the WHO.
Go to shock.
So WHO, see, because pain itself can cause lots of other problems. They can cause systemic, vasoconstriction and all these kind of things. So what you have to do is to assess the patient. If the patient is in severe pain, don't hold either morphine or pethidine from them. Give them 1 shot or 2 shots. Get the pain under control. Then you can give the milder drugs. But in patients who are mild pancreatitis, you don't have to give them, morphine or pethidine. Start with the paracetamol or whatever. So the pain management depends on the severity of pain and also severity of the disease. Okay.
Yes, sir.
So not always do you follow the WHO ladder. Everything has to be customized.
Yes, sir.
Okay, continue.
The further management is directed at the etiology of pancreatitis, as in the case of biliary etiology.
Indraja, wait, ma. Indraja.
Yes, sir. Yes, sir.
When is the ERCP indicated in acute pancreatitis? And what is the timing?
Sir, if it is showing if ultrasound shows any presence of gallstones, like any passed out calculus, any stones in the CBD or passed out calculus, generally we'll do after 48 hours, ERCP.
Okay, so you have to be very clear. Patients with dilated CBD, what is the normal diameter of the CBD?
7 to 8 mm, sir.
Oh God.
4.
4 to 5 mm.
Yes,
it's not
sorry.
7 to 8 is dilated.
Dilated, yes.
In a 70-year-old, what is the normal diameter?
6 to 7 mm is
So
normal.
sir.
No, in up to 1 centimeter is normal in older individuals.
Yes, sir.
So
Sir,
you have to be careful. Whenever you comment on this, it has to be age dependent. So, but ductal pancreatic CBD ductal dilatation, presence of smooth tapering with possible foreign body or stones in the terminal CBD, and or presence of gas in the CBD, and elevated or abnormal liver function tests. For example, direct hyperbilirubinemia with the elevated alkaline phosphatase and gamma GT. So these are the indications for and patient who has clinically jaundice. So these are the indications for ERCP. You have to do the ERCP as soon as possible, as soon as the patient is clinically stable. Don't wait
sir.
for because if you don't intervene early, you may push a mild pancreatitis into severe pancreatitis. So you have to
Yes.
do the ERCP early. You don't have to
Yes.
do the lab chole early, but you have to do ERCP early. You have to get a MRCP in these patients, get a roadmap and then do the ERCP. Okay, because again, ERCP itself can aggravate the pancreatitis. So you have to be careful. Your indications for ERCP should be, set in stone. There should be hard indications because ERCP itself can cause complications. So especially pancreatitis. So in the setting of an acute pancreatitis, if you cause more problem, then it can exacerbate the problem. Hence, the indication for ERCP should be there, definite, and then the timing should be as soon as the patient is clinically stable. Okay.
Yes, sir.
yes, sir.
Nikitha, can continue, ma.
Yes, sir. So usually acute peripancreatic fluid collection resolves spontaneously in most cases, and only less than 10% results in pancreatic pseudocyst. Most pseudocysts decide with observation along with the periodic follow-up using CT or MRI. Drainage of this pseudocyst is only recommended in case of infection or rapid enlargement.
In what most pseudocysts decide with observation means what?
Not decide, ma. They get better. I don't know what decide you use. Decide.
Subside, sir. I mean, decrease.
Subside. Yeah, subside. Okay.
Yes, sir. And necrotic collection management remains challenging. The sterile collection is intervene if it causes symptoms.
No, wait, ma. Wait. Nikitha, see,
Yes,
I told you all this surgical management of acute pancreatitis itself is a big class.
yes, I
Because
just
we
mentioned one
cannot
line.
cover it. We can't cover all of this, and you will be just touching it. So
Yes,
They
sir.
come
here.
usually after 2 weeks, no?
It's already 10 o'clock now. So let us stop here. Any questions?
How many this thing is there?
Sir,
How many more slides are there?
just 2 more slides, sir. I just mentioned one line about the surgical intervention and just prevention, sir.
Okay,
Prevention
go
of
on.
recurrence. That's it.
Finish.
Okay, go on.
Yes, sir. So, this is surgical. New treatments are ulnastatin.
Hey, why you are skipping? Tell the previous. Yeah, tell.
Yes, sir. Antibiotics are initiated on an early suspicion, as in case of any source of infection, which includes carbamazepine alone or a combination of.
Not carbamazepine, carbapenems.
Sorry,
Why
sir.
are you making mistakes like this? Carbamazepine is a painkiller, anti-epileptic.
Anti-epileptic.
Yes, sir. Carbapenem alone or a combination of.
He might have given a lot of this thing presentation to her carbamazepine.
Combination of quinolone, cefepime, and ceftazidime with metronidazole. Gas bubble diagnose infected.
No, you should know the cause to give all these antibiotics also. Because it is time 10 o'clock, you should know. Tell him next time.
Yes, sir.
Why these antibiotics are preferred.
Okay, sir.
Hmm.
Gas bubbles diagnose infected necrosis on imaging and CT guided percutaneous aspiration culture. So, surgical necrostomy is performed in patients who continue to deteriorate clinically despite antibiotics. And in stable patients, antibiotics are continued for 4 to 6 weeks. And necrostomy is performed after the wall.
Necrosectomy.
Necrosectomy, sir.
What is wrong with you today, Nikitha? You are making so many mistakes.
Nothing.
Hurry.
No, sir.
Ah.
No.
Hmm.
Newer treatment modalities are ulinastatin, an intrinsic trypsin inhibitor, and gabaxate is a synthetic serine protein inhibitor.
You
That
give
is-
the reasons all this in WhatsApp.
Yes, sir.
Why you are using this, all those things?
Yes, sir.
See, so to sum up, pancreatitis is a very severe condition. I think the main thing is to make the diagnosis of the severity of the pancreatitis as soon as possible and stratify the patient so that you can manage them effectively. And we will go for the surgical management of acute pancreatitis in the next class, because I think it's a vast topic in its own, on its own. And also, again, sort of, let us see, we will also, what shall we say, expand on the indications for ERCP, the timing
Management
of
of complications also.
complications, and the timing of cholecystectomy. All of these things we'll talk about in the next class. Okay.
Okay, sir.
Okay, I think Srikanth, your final comments.
Yeah, very good presentation. No, whatever the new drugs, all those things, give the reasons why they are this thing and in what conditions they have to give.
Yes, sir.
Good presentation. But you should present little slowly because it's the main
Sanya?
question.
Yes, sir.
Every alternate years you will get the main question in this one.
Sanya, your comment.
Yes, sir. Sir, she presented very well, sir. She's covered almost all the topics. She's touched upon all the important aspects of acute pancreatitis. It will be helpful for Indraja and Pawan also, sir.
Okay, Nikitha,
Yes, sir.
I am not going to be as charitable as Srikanth and Sanya were. I think knowing your potential, your presentation today was not up to the mark. There are lots. I think
Charitability I learned from you, man. You are.
no,
I was more harsher than you before.
So I think there were lots of lacunae in your presentation. In terms of the etiology and lots of things, and the flow was not there. You are making lots of mistakes. You are capable of much better presentation. So take cognizance of in today's class, and then actually I'll tell you, I listened to the lecture that I gave that day, not because I wanted to hear my own talk, but I wanted to know how could I do it better. So I think that is important for all of us to keep on looking at the mistakes and critically analyze what we do and get better every time. So you need to look at this, go through this presentation again once they put it up, on the YouTube. Go back and see where you can do better. Okay.
Yes, sir.
Okay. Good night.
Thank you, sir.
Thank you, sir.
Thank you.